Hello, I'm Dr. Morse, and today we're going to go over session 1 of Public Health in the Rural Community. An overview of the lecture. We're going to go over the social and economic status and how that might impact health risks. We're going to talk about the difference between clinical medicine, public health, and population health. And we're going to discuss the organization and function of public health in Michigan. Now, social and economic status is typically referred to as socioeconomic status, or abbreviated SES. The importance of SES has been known for centuries. And you think of slaves building pyramids in Egypt, or laborers working with mercury on hats many years ago. But even as differences in sanitation, housing conditions, and the major differences between classes have improved, lower socioeconomic status has still been associated with an increase in morbidity and earlier mortality. The causal relationships are still debated, as there are many compounding factors here as well. It's difficult to conduct good, solid research studies to be clear about these relationships, but it is clear there is a relationship. Whenever there's a social economic status gradient, you will find a health impact. So if you have a lower level employee and their boss or employer, there will be a difference in their health status. When socioeconomic status is looked at, it's usually categorized in one of three main categories: education level, employment or lack of employment, and money or income. First, we're going to look at Michigan in a broad stroke at some of the different socioeconomic statuses that we face compared to the nation as a whole. The data that I'll be using for many of these slides comes from communitycommons.org, and it's a very useful site if you ever need any similar data for any areas in the country. So looking at the education level in Michigan, we're actually doing better. This is showing that fewer than the national average do not have a high school diploma at age 25. So more people than average do have a high school diploma. However, fewer than the national average have a bachelor's degree. We're about the same when it comes to unemployment rates in Michigan compared to the nation. Michigan's poverty level is higher than the nation. The extreme poverty level, that below 200% the federal poverty level, is about the same as the nation. The average income a Michigander makes is less than the average income others in the United States will make. Families earning over $75,000 is less than the number of families earning that much in the United States. Families in Michigan are more likely to be on public assistance and more likely to receive SNAP benefits, which is Supplemental Nutrition Assistance Program benefits, or food stamps. Food insecurity, or feeling as though they didn't have enough food or adequate food, is about the same as the nation. And we have a lower teen birth rate than the nation, so that's a good thing. So I know I went quickly through that, and if you need to go back and look at some of those slides, you can, but I put it into a summary table here for you. Green check marks indicate that the levels in Michigan are better than the United States averages. Yellow means we're the same, and red is that we have higher or worse rates than the nation. So Michigan has more red check marks, unfortunately, than yellow or green, it looks like. So the next two slides we're going to look at are using data that comes from the health outcome rankings. These reports are done yearly by the University of Wisconsin, and they're looked at quite seriously as indicators of how counties are doing based on many different factors. This first chart, or first map, shows how counties are doing based on health factor rankings. And health factors include smoking, obesity, food environment, inactivity, access to opportunities to exercise, excessive drinking, driving while intoxicated, STIs, and teen birth. Now, darker colors are worse rankings. Lighter colors are better rankings. The next one shows health outcomes. So these would be premature death, poor or fair health as rated by the patient or the person completing the survey, poor physical health days, poor mental health days, low birth weight infants at birth. So again, dark is worse. Now, here I have pulled more data from the Community Commons, and this is the population density. So lighter areas have less dense population. The counties outlined in red are counties that were more than 70% or 70% or more rural. Some of these areas that aren't outlined in red are still pretty yellow. So one would argue that these are pretty darn rural. But based on the data, these red outlined counties were the ones that were indicated as 70% or more rural. And today we're really talking about rural health and its impact on socioeconomic status and other factors. So look at these three maps compared to each other. The red outlined counties, do you notice any correlation or relationship to where these darker counties are? One area that you might see turning up again later is sort of this area here. This line and this area up in here seems to be a difficult area, an area that has a lot of trouble. But basically what I see, and this is kind of a broad stroke impression, but this northern part of the mitten is a bit darker. Certainly the health factor rankings are a little bit more scattered. Now, the county health rankings found some commonalities in their studies. Rural counties have had the highest rates of premature death for many years. So their research has concluded that over the years, and this is going back to 1997. So this is looking at years lost. Rural areas are dealing with the most years lost, and it's been worsening. Urban and suburban areas have actually been improving over time. There's really not any single reason to explain this, and so that's what makes it tricky, is there's no single intervention that can help fix this. But that is one common feature that county health rankings have really determined or found, is that premature death is a risk in rural areas. This is a busy slide, but the main points are that this is another finding from the community health rankings. In rural areas, which are indicated by this blue R, consistently worse in rural areas is adult smoking, adult obesity, teen birth, uninsured rates, preventable hospital stays, only having some college, or I should correct that, having had some college education. So rural areas have the least amount of advanced education, children in poverty, and injury deaths. Now, in rural counties, we have the best rates of not having to have a long drive or commute, and the least amount of violent crime. So we have those things going for us, but lots of other risks and issues happening. Another thing that the county health rankings have shown is issues with drug overdoses. I'm sure most of you have heard about issues with drug overdoses increasing over the last decade or two, and rural counties have had higher rates of this increase. This used to be considered a more urban issue, and it's definitely spread into the more impoverished rural areas. We're now going to turn our attention back to those 70% or more rural counties. There's 34 of those counties overall in Michigan. 70% was just an arbitrary number that I picked to focus on. The counties that are colored yellow are counties that I cover. I just listed those there. It's about a third of the counties that are highlighted in red. I would argue that the 19 counties I cover are all rural. And again, it's pretty much all this yellow area here, but I had to pick an arbitrary point to look at. So now this shows the population with no high school diploma by age 25. So it is a bit higher than the Michigan average. Not by much, but you can see, again, darker is worse. There are some pockets here where it is worse than the average for this whole area. This is looking at on-time graduation rate, and actually it's better. There's a higher percentage here, so more people in this area are graduating on time, so that's actually a good thing. There are low levels of people going on to getting a bachelor degree or higher in this area. And here's that angle here. It's interesting how that pattern kind of repeats itself. But unfortunately, not much advanced education. It would have been interesting if they had looked at associate's degrees or trade school education, such as heating and cooling, as there are several colleges and centers that do that type of education in the rural areas, but they just looked at bachelor degree and higher. This is unemployment rate, and it's average compared to Michigan and the nation, and this was from September, so it's quite recent. Back 5-10 years ago might have been quite a bit lower, but lighter is worse. No, I'm sorry, darker is worse, and there are some pockets where it is a bit worse. And definitely the lighter areas are in the more southern urban areas. All right, so poverty level. The areas below the poverty level, it's about the Michigan average, but again, some areas here, got that line there, the dark areas are over 20%, and so there are some areas here that are quite high on poverty. Unfortunately, we have above the state and national average on extreme poverty, so more than 200% of the federal poverty level. So this is very unfortunate. Again, these mid-state counties here, more than half the people are below 200% the poverty level. So that's really unfortunate and makes things really challenging. Per capita income is lower than the state average, which is much lower than the national average. So again, we see this center of the state issue here. And there are some pockets here where that's a bit better, but definitely areas are struggling. Family income over $75,000 is definitely lower than the state and national average. And it is right in that center area on up. I grew up in Clare County. I practiced medicine in Clare County, and I still live and raise my family in Clare County. And it's interesting, they call it the gateway to the north. That's kind of the county and town saying. So it's unfortunate that the gateway to poverty and difficulty tends to be this area as well. So it's just very fascinating that that line tends to persist through a lot of these issues. Food insecurity, fortunately, does not seem to be an above average issue. There are some counties, though, again, that are quite dark. Lake County is one county that has had quite a bit of struggles, and very low income is one of the poorest. In fact, the last report I read is the poorest county in the state. Households receiving the SNAP benefits or food stamps is right about at the state average, which is again above national average. But as you can see, some of these counties are quite a bit darker than the others in the state. Households receiving assistance is around the state average. Households or individuals that are insured by Medicaid, however, is above the state and national average. Now these next few slides are not the traditional socioeconomic status type factors, but are interesting and do portray some of the issues you might think of in rural counties. These are the birth in teens rates, and the rural areas are pretty average compared to Michigan and the US, but there are a couple of counties here that are pretty high. I know Clare County has had quite high levels for some time, unfortunately. The adult smoking rates are well above the state average and the national average. This report came out this past fall, 2016. This is the rate of smoking in mothers during pregnancy. And if you'll see here, this report specifically says that counties with smaller populations experience the highest rate of mothers smoking in pregnancy. So in other words, rural counties have the most smoking in pregnancy. So here we have Lake and Clare County. Those counties seem to have higher rates. Actually, this is Roscommon County, I believe. But again, this northern rural area seems particularly hard hit with maternal smoking, and that has a lot of risks that can be long-term for that baby. Heart disease risks higher in this area compared to the state and the nation, and that can be for multiple reasons. And again, we're not really looking at the reasons why here, it's just something of interest. This is one that really bothers me, and this is mental health care provider rates per population. And, this area is particularly stricken with mental health issues because of the socioeconomic status, but has very low access and provider ratio to mental health care. So again, we see this line right here again, and really struggle with access, really struggle to get appointments with mental health. Again, we saw that they have a higher than average Medicaid population. Medicaid patients can really only get mental health through community mental health, and if there's not enough providers, then they're really stuck, and that can really affect their ability to work and participate in family care, and so it's a very, very vicious cycle. So that's a really disheartening statistic to see. So a real broad overview, based on the averages in these counties, they have less advanced education, individuals in general, are paid less, and have higher levels of extreme poverty. But as you saw, there were several counties that stood out from the averages and had many other struggles that stood out and above from the average of the other rural counties. We're going to shift gears now and talk about the differences between clinical medicine, public health, and population health. According to the Harvard School of Public Health, and keep in mind this is according to a public health school, clinical medicine primarily focuses on individuals. The emphasis is on disease diagnosis and treatment, and treating the individual patient, which of course we need that. We still need clinical medicine, very important thing. The predominant emphasis is on medical care, and there is a uniform system for certifying specialists beyond the professional medical degree. And I think we'd all agree with that. So specialists could be certified either based on the organ system, the group of patients that the physician serves, the type of disease or pathology that is being taken care of, and the type of skill that the physician treats. The medical field is really stimulated by the needs of the patient. Research moves from the laboratory to the patient or the bedside. Their opinion is that the social sciences tend to be an elective part of medical education, and I really disagree with that. I felt, at least in my education, that the social fields and the social part of a patient's health was highly emphasized, and we were very much educated on it. However, in reality, when you get into clinical practice, there is not an incentive to deal with the social side, and there was not time to take care of the social side as much as was needed. So I don't feel it was a lack of education. I just feel that the modern medical field in the United States does not allow for it in practice. Now, public health, the primary focus is on the population as a whole. The main focus is on prevention and health promotion. There may be several different interventions that are used to impact the population, and there's different ways that practitioners of public health are specialized. So, go on here. So that might include the way that the specialist uses analytical methods like epidemiologists or toxicologists, the type of setting that the practitioner works in, whether it's global health or working in the occupation, or just the type of problem they're dealing with, so environmental health or nutrition. So with this type of work, the research moves more between the laboratory and the field rather than an individual patient. Social and public policy are very important parts of this education, and that's a real primary part of it. Now, anyone who's studied public health at all has seen the three core functions of public health. They are assessment, policy development, and assurance. Assessment is actually a huge part, and a lot of that we just went over. That's basically researching facts, figures, and statistics, and it actually is quite important. You can't really make a change unless you know what needs changing. If you feel like smoking rates in pregnant women need to be addressed, but say your county has at average or below average maternal smoking rates, is that really the best use of your time? So that's what we're looking at. The other thing is you need to know how your citizens feel about it. So if the community has absolutely no interest in making changes in their smoking habits, it's going to be a difficult thing to impact change. And so you may need to start at a different point than encouraging change. You may have to start at more of an education point. So the assessment part is a huge component. After that comes policy development. So again, once you know what the problem is and you know about your community's feelings on the matter, you can start to make a policy. And I have learned in my time here that everything has a policy. And so basically it's your blueprints for what you're going to do. Assurance is how are you going to make sure that you're doing what you said you're going to do? How are you going to look back and measure that you're doing it well and that it doesn't need to be changed or tweaked? So in those three main functions are the 10 essential services. There's monitoring health status, diagnosing and investigating, inform, educate, and empower, mobilize community partnerships, develop policies and plans, enforce laws and regulations, link people to needed services and assure care, assure a competent workforce, evaluate health services, and do research. And those essential services are touted again and again. If you ever do any work or learning in public health. So those are the essential services. Now, population health, to me, it's a bit of a confusing term. It's often interchanged with the term public health, which really is not correct. Cohen and his co-authors did a survey of some of the leaders in population health, and they used several different definitions and described different elements of population health. They felt it was a focus on health and wellness as well as prevention. It was taking a population-oriented approach. It was working on community outreach. It was working on addressing social and health determinants. It was working on partnerships with other groups. And it was really focusing on vulnerable groups and health disparities that are in those groups. Some other elements that have been described in population health is shifting from the service-based approach to a person-centric. So looking at that person and assessing all of their needs. So do they have a house? Do they have enough food? Do they have transportation? Rather than, you're sick, here's some medicine to get better. It's more of an ideology and a bigger picture type approach. It's a long-term approach, which can make it, again, more complicated. So we're looking to improve the health of a big group of people. So if we're looking to improve the health of rural northern Michigan, how would we go about that? It includes everybody. It's not just the work of the government. It's not just the work of a nonprofit. So again, it's not necessarily tied to your local health department. It's going to include the healthcare facilities. They're going to work with a nonprofit group. It's going to be a conglomeration of all the parties that can work together. Now, there seems to be a disconnect between the private sector in medicine and public health. Now, Dr. Flexner recognized in the late 1800s that physicians needed to become more focused on preventative care and the social factors in their patients. And at that time, he criticized medical schools for not including that in the education of training doctors. And so initially, public health and medical education were included together. That was all in one setting. And that broke apart, and we'll go over in the next slide how that happened. But still today, the U.S. has a fragmented education where public health and medical education are two separate educational entities. And we're one of the few developed countries that treats it that way. So the turn of the 20th century, so in the early 1900s, public health clinics were providing care to mothers and children or newborns. And physicians at that time were feeling like it was encroaching on their business. So they saw that as a threat to their business. So that was one issue that kind of led to the split between public and private health. Next, in 1916, the Rockefeller Foundation decided to create schools for public health. So that made public health schools separate from medical schools. So that sort of officially divided them. This actually has been a big deal. What's happened now is physicians may not think about public health the same way and vice versa. It's hard to attract physicians to public health. Preventative medicine, which is actually a specialty and there's a residency in it, has a harder time attracting physicians, and it's just harder for everyone to understand what each other does. And having been someone who, until recently was in the private medicine sector, I clearly see the difficulty of each group really working together well and understanding what each other does. So the public health system in Michigan is obviously made up of state and local governments, but the communities play a factor. There's drug prevention coalitions and things like that. The healthcare system certainly plays a role with infection control and a variety of other things. Employers and businesses play a role. They may do employee wellness programs. Media plays a big role if we need to get out some information about an outbreak, or they may get out misinformation. And universities and colleges play a big role. We've had meningitis outbreaks or things like that where they've played a big role in helping us. So it's really made up of lots of people. I would throw in there that it's made up of families and daycares and schools and all kinds of other people that are very important. Interestingly, our public health system in Michigan began in 1873 with the State Board of Health. It was created initially because explosive oil lamps were catching flammable arsenic wallpaper on fire, and that was causing a lot of death and disability. Right around that time, most other states were creating a Board of Health as well because of tuberculosis and cholera and other contagious diseases. So we weren't unusual in that respect. It's just an interesting reason to finally push us over the edge. In '96, the Department of Public Health was combined with some other departments, and the Michigan Department of Community Health was formed. And then in 2015, MDCH was absorbed by MDHHS. So it's really a huge, huge office now. So this is just one page of the 112-page organizational chart for MDHHS. The department that local public health would report under is right here. And that's continued over here. So this is the population health, as they call it. You'll see here, Bureau of Local Health. Now, as I'll explain in a minute, we're not really run by MDHHS, but they do provide us with assistance. But the laboratory works with us quite a bit. Lots of help from this branch. But Medicaid is under here and many other huge groups. And so it can be challenging when you're part of such a big department in terms of funding and organization. But the individuals that we work with are overall very fantastic. Public health in Michigan is primarily run by local government. So there's 83 counties in Michigan, and we're served by 45 local health departments. There are 30 single county health departments, which are in white on this map, and there are 14 district health departments, which are in color. And a district health department is where several counties form into one larger health department, usually because they have a lower population. Detroit is a large enough city where they have their own health department, and then Wayne County also has a health department. Each health department is part of the local county government, and it's separate from the state government. In the nation, all of the counties that are this army green have local health departments. So the health departments are run by local government. Purple have mixed, where it's run by more than one government type. The khaki states here are run by the state, and the red have shared governance between state and local. I cover 3 districts, so I cover these 19 counties. Of those 45 health departments, there are about 27 medical directors. So clearly, most medical directors cover more than one health department. Now, to go over how a local health department is operated, I'm going to focus in on Central Michigan District Health Department. And that's a 6-county district. And these are the branch offices. Isabella County is where the administrative office is, and that's where most of the administrative staff is. And this is the administrative organizational chart. You'll notice on the top is the Board of Health. And when we talk about local government running local health, it's run by the Board of Health. Board of Health is comprised of county commissioners. Those are elected officials. Then 2 county commissioners from each county, at least in my situation. It might be different for single counties, how they do that, or for Detroit certainly. But 2 county commissioners from each county are then assigned to this board. They have several other boards they have to serve on as well as part of being a county commissioner. Very rarely will you have someone who volunteers or asks to be on the Board of Health, but most of the time they are assigned. Sometimes they have absolutely no desire or really don't want to be on the Board of Health. Almost never do they have any medical experience or background whatsoever. It can be challenging, especially when you're talking about things like family planning, immunizations, topics that can be a bit of a hot button item when you're dealing with some more conservative type politicians. So that can be a real challenge because, again, they're ultimately running the health department. So it's our job to really educate them. For the most part, they let us do what we need to do. Next in command is the health officer. So he's basically the boss beneath the bosses. And again, the health officer really builds trust with the Board of Health so that they can make the decisions that need to be made because they understand the system. Underneath the health officer are all the variety of directors of all the different programs. And we'll go through that in a minute. First here at Central Michigan District Health Department, at least, and this is a pretty typical position. We have a director, I know it says environmental health there, but that's a typo, director of personal health. And so she covers programs such as communicable diseases, immunizations, WIC, and so on. And we'll talk a little bit more about essential services in a minute. There are 6 supervisors under her, 1 for each county. And then nurses, receptionists, dietitians underneath there. This is our health promotion and preparedness supervisor. She supervises the breast cancer, cervical cancer navigation program, family planning, STD, HIV, those types of programs. They have a traveling clinic for the most part, and underneath that would be our nurse practitioners, nurses, receptionists, things like that. Our environmental health director supervises our sanitarians and their secretaries, and they do water testing, well and septic, and so on. And we'll talk a little bit more about that too. Now, in terms of a medical director, again, like I said, I believe there's 27 of us covering the 47 health departments. Some are part-time, some are full-time. This description comes right from the Public Health Code. So medical director is a physician who qualifies as a medical health officer, which I'll describe in a minute, who is employed by the Board of Health. So again, they're my boss, to provide direction and formulation of medical policy. And then it goes on to explain that basically any medical procedure, standing order, or advising of anybody is under my purview. Investigating epidemics and diseases, things like that are all the medical director's responsibility. Now, a medical health officer is a physician who is board certified in preventative medicine or public health, which I mentioned earlier was a residency, a specialty that you can go into, or has an MPH, Master's in Public Health, and not less than 2 years of full-time public health practice, which, I mean, how do you get that without working in this job? But has not less than 3 years of full-time public health practice and 24 graduate credits acceptable towards public health degree. So had I read this, I would never have applied for this job. There is an exception, and this is how a lot of medical directors begin, and it's the way I started. You can get hired as a provisional status, and the state approves your hiring. Again, you're provisional, and that's while you're pursuing your MPH, and you're assigned or you choose another medical director to be your mentor. And in reality, all of us are in frequent contact with each other and help each other out quite a bit because there's so few of us and it's such a unique position. So there is a way to go around these qualifications. Now, a health officer, I believe there are 44 of them at this point, so many more. I'd never heard of this position before I had this job. They are required to have special training in public health. However, they could have a variety of backgrounds. They could be a health educator, they could be a former environmental health employee. So it could be a variety of backgrounds and knowledge base. They are the ones that have the legal authority, but they can also delegate that. So they can declare a public health emergency. They notify the public about issues. They're really the spokesperson for the agency and the ultimate administrative authority for the agency. Now, in the local health department, there are essential services that have to be provided. And those are supposed to be funded, at least in part, by the state. From what I've been told, the state has never fully funded what they're supposed to, but we still get by. So essential services include immunizations, infectious disease control, STD control and prevention, hearing screening, vision services, food protection, so that would be, restaurants, things like that for foodborne illness protection, public and private water, and sewage management. The other requirements that health departments need to provide are family planning, health education and nutrition services, which would be WIC, HIV testing, serious communicable disease, which primarily is TB control, hearing and vision screening, public pool inspections, campground inspections, pregnancy testing, and again, drinking water testing. So immunizations is a big part of what we do. Big thing is to make sure that all kids going into school have been vaccinated, and those that refuse, we do work with the waiver system now. Infectious disease control, there is a specific list of reportable diseases, and when there is a case of one of those diseases, we really do investigate it and do any measures needed to help contain it and to help stop any outbreaks from occurring. STDs, again, screening, prevention by providing condoms and education, treatment, expedited partner treatment, primarily of syphilis, gonorrhea, chlamydia, and HIV. But I consider HPV one of those too. Hearing and vision screening in the schools is done by our staff. Food protection, this includes prevention. Our environmental health staff do Serve Safe. They teach restaurant staff how to properly handle food. If there is any suspected foodborne illness, They will inspect a restaurant and will do an outbreak investigation. They license and inspect restaurants regularly. Well inspections, permits, sewage inspections and permits. So as you can see, there's a lot of things that go on in a local health department. In the rural areas, it can be very challenging, but very interesting. So hopefully you got a good overview today. I know it was a bit daunting and a lot of statistics, but basically just wanted to show that the rural northern areas definitely have their struggles, and treating certain illnesses may not be as simple as giving them a medication. You may have to assess their ability to get transportation or to afford certain things. If you have any questions, don't hesitate to contact me. Thanks for listening.